drugs for heart failure and inotropes. Okay, so we will start little bit with physiology and then go to the drugs and the ones what we are using today, as of today, and as well as recent advances. Just a glimpse of these things in 1 or 2 minutes. There are two types of action potentials, one in the ventricle and one in the atria. Both are differing. In ventricles, there are fast channels. So you have phase 0, 1, 2, 3, 4. Phase 0 is resting, 1 is sodium entry, 2 is sodium exit, 3 is calcium entry, and 4 is again repolarization, potassium coming out of the body, and then the action potential again starts. Whereas in the slow channels, that is in the atria, it's mainly calcium predominated. So you will find the difference when we add some drugs, they act only on the ventricles but not on the atria. So you can answer those questions which usually comes in CET and when you are practicing also. Why this should not be used in the initial stages of your practice. I think you should find some little difference regarding these things. Okay. Next, again, same thing I have depicted in a little nicer way. Phase 0, 1, 2, 3, 4. This is more important, mainly in the SA node, AV node, and His-Purkinje system. But in the atria, during phase 4, there is a gradual increase in the transmembrane potential. Again, spontaneous depolarization and automaticity occurs. So if this goes on as usually, then it will be a normal action potential. Suppose in phase 3 itself, again the repolarization starts, then there is generation of arrhythmias. Okay, so otherwise, if this completes, then there is no problem. But whereas if it does not complete, it leads on to arrhythmias. Whereas if the action potential duration, that is from phase 0 to phase 3, is increased or decreased accordingly, you have various phenomenons in cardiovascular system, which we will deal it in the later period or in the next class. Now, the components of these heart muscle tissue is action potential, what I showed you just now. Then cardiac contraction occurs mainly by two mechanisms. One is through sodium potassium ATPase pump, as well as calcium, which enters from the extracellular and also increases in the sarcolemma. Both these put together, the calcium is the main one in the cardiomyocytes, which determines the contractility, as well as L-type calcium channel blockers in the cardiac myocytes. These two are responsible for the cardiac contraction, normal cardiac contraction in a physiologically normal system. So in heart failure, what are the compensatory physiological responses in heart failure? So I think you know a little bit of heart failure. Where the main cause, at present, the main cause is usually hypertension. You have so many cardiac causes, so many, umpty number, but the main and the most prominent one is obesity leading on to hypertension, and then if not treated properly, leading on to heart failure. But in the previous class, I have already mentioned, because of better drugs and identifying and awareness of hypertension in the early stages, and administering AC inhibitors, especially, or combination of drugs with AC inhibitors, calcium channel blockers, and diuretics, if the patient is quite aware, going on to heart failure is absolutely nil. I had a few patients where they died only of aging problem with hypertension rather than heart failure and other components. They were very active even at 80, taking a small dose of AC inhibitors or calcium channel blockers. So timely recognition and awareness from the patient's side, as well as giving proper treatment, and then telling them to come back to see the doctor, not for the money, but for all these things, for to at least to combination of drugs, or to look at the adverse effects, change the drugs dose, and tell them to take at the proper time, chronopharmacology. All these will help for the patient to maintain a good quality of life for whatever time the God has given to them. So in heart failure, as all of you know, there is hypertension. Initially, hypertension will cause these things, and in heart failure, what is happening? The blood flowing into the heart is less, and so to the kidneys also. There is renin secretion. All these things will happen, and hence the heart cannot contract properly, so that the ejection will be a problem. So initially, before the drug treatment, what all impairment can occur? The first thing is increased sympathomimetic activity. So body tries to see that somehow it regains the normal thing. So sympathetic or sympathomimetic activity increases. That means adrenaline secretion increases, beta 1 activity increases. All actions are increased except the flow to the coronaries. So they might have even MI during these activities also. So this is the main one. Next is RAS activation. Apart from that, sympathomimetic beta 1 main it is. Apart from that, you have even alpha, which causes vasoconstriction. All these things are there, but the main one I'm targeting is beta 1 in the heart, and also beta 1 activity, increased activity of renin. RAS activation, as all of you know, renin, angiotensin, aldosterone system, where the renin initiates angiotensinogen, which will stimulate angiotensin 1 to 2, and angiotensin 2 acts on the receptors, which is the most powerful vasoconstrictor in the whole of the body, and it is a mixed vasoconstrictor. I hope you remember all the 10 words what I had told you in the last few classes. That is, once it is a mixed vasodilator, that means it dilates, constrictor. It constricts both arteries and venules. Both of them are constricted. So diastole and systole is increased. The left ventricular and diastolic pressure and volume is increased. Cardiac output is increased. Force of contraction is increased. Again, roundabout, you have systolic and diastolic being increased. In turn, coronary flow decreases, and because of these activation and increased blood volume, together with aldosterone activation, what's happening? The heart is getting strained. So it tries to pump and pump and pump, thereby it goes to remodeling and fibrosis as well as apoptosis. So these are the problems which are met, where further you see that the ventricles cannot contract properly, where we can say it as a diastolic heart failure or a systolic heart failure. Then the third one is activation of natriuretic peptide. These are actually better if they are secreted. They cause vasodilatation, natriuresis, RAS inhibition, and reduce myocardial fibrosis. Now, of late, in the recent advances, we are targeting at these also, so that there is more of these things. But given alone is a problem, so we are using in combination with an ARB. Lastly, myocardial dysfunction occurs. The ventricles will get enlarged. They cannot contract properly. Blood ejection will not be complete. Ejection will be less. And so in the atria, there might be little blood which is uh, there inside the atria, which can lead on to thrombus, and this thrombus can go directly to the cerebrum, causing cerebral thrombosis, etc., leading on to the complications of heart failure. In this, you have to remember one more: the decompensated heart failure. See, you have nowadays we have got two types. When the systolic activity is decreased, where we call it as heart failure with reserved ejection fraction, and when it is diastole, it is preserved systolic function. One it is reserved, one is preserved systolic function. Now, a word or two about these to know in the practice points. Ventricles are not supplied by parasympathetic nerves, and negligible effects on the ventricles on vagal stimulation. Upon vagal stimulation, what's happening? The vagus is slow to the heart in stimulation to the stomach. So once it is depressed to the heart rate decreases. But as ventricles are not supplied by this parasympathetic nerves, you see that whenever arrhythmias occurs and we give atropine, it is of absolutely no use. It acts only through SA node and AV node, not further things. And so we should make out different modalities than just giving atropine, what we see in the Hindi movies normally, which we used to see previously. These should be remembered as practice points because these are the ones what we come across day in and day out. Drugs precipitating heart failure, in fact, any cardiovascular disease, are NSAIDs. So amongst NSAIDs, so to say, paracetamol is quite okay or safe, but not others, because all are prostaglandin inhibitors, where it inhibits the prostaglandins vasodilatation in the kidneys, and hence it is a harmful effect, causing edema, decreasing urinary output, and so on and so forth. So these are the problems meant, and NSAIDs are, as all of you know, it's over-the-counter drugs, right from aspirin to celecoxib. They are all over-the-counter drugs, so patient can take as and when they like, and it is a horrible condition to see that they come because of drug-induced diseases or iatrogenic diseases. Next is alcohol. As all of you know, this is one of the most problematic thing what we have in this world, where the whole body is affected, right from brain to toe. And non-dihydropyridine CCBs, that is verapamil and diltiazem, are known to produce heart failure because they block the L-time calcium channels in the heart, in the cardiac myocytes, where they will decrease the heart rate and they can go on even to the heart block. Antiarrhythmic drugs are all pro-arrhythmic also, and they prolong the QT interval. So by this, the pumping effect might be altered, and hence they can precipitate heart failure in the pre-existing ones. Now, these some of these terminologies you have to uh, be familiar with these terminologies. Okay, you have to be familiar with these terminologies. Capacitance vessels, where veins, it relates to veins and venules. Resistant vessels will determine for arteries and arterioles. Preload determines the volume overload and the atrial pressure mainly. So here, when the preload is increasing, end diastolic filling pressure of the heart is increased. There is rise in systolic BP, which can be reduced by dilatation of the capacitance vessel. That is the veins. So nitrates can be used and reduce and reduce circulatory volume by diuretics. By diuretics, you reduce the circulatory volume. Dilatation of the capacitance vessels, that is the veins and the venules, are dilated mainly by nitrates, but we have mixed vasodilators, that is AC inhibitors and ARBs. The intravenous ones are sodium nitroprusside, but that we are not going to use in our OPD practice or in our regular things. So the main dilatation of capacitance vessels are, first one are nitrates in order of choice, and the second one are AC inhibitors and ARBs. Afterload will see to the pressure overload. So this afterload is mainly for the resistant vessels, that's the arteries and the arterioles, against which the heart acts and pumps the blood. So there is increased peripheral vascular resistance. What do you mean by peripheral vascular resistance? In the blood vessels, what we see to it that this resistance is carried out whenever there is vasoconstriction. There is increased resistance. Whenever there is vasodilatation, there is decreased resistance, which whenever there is increased vascular resistance, it leads to rise in blood pressure, mainly diastolic blood pressure, where it is reduced by dilatation of the resistant vessels. And the reduction of dilatation by resistance vessels is mainly by calcium channel blockers, and also, so to say, alpha blockers. So depending on the patient's condition, we use either of them. The others are mainly diazoxide, minoxidil, and hydrolazine, which have their own problems, and most of them are given by parenteral route. So these two are the ones where we use normally orally. Next, cardiac output is the amount of blood pumped in 1 minute. Amount of blood pumped in 1 minute, where we can see in the pulse or the heart rate, and see that the 1 minute heart rate is how much. So accordingly, we can calculate the cardiac output. Stroke volume is the amount of blood pumped in systole. Amount of blood pumped in systole, and normally it should be 5 liters, where it decreases in the majority of the cases to very less, and the ejection fraction is the determinant, and usually this will be lessened. Normally 55 and above is considered to be normal, and if it starts decreasing, accordingly we denote it as stages of heart failure according to New York Heart Classification, where there are about 4 stages, 1, 2, 3, and 4. Lastly, a word about peripheral vascular resistance, where I told you already, due to diastolic BP and increased and decreased by the vasoconstriction, vasodilatation of the resistant vessels accordingly. So these are the common terminologies what we use henceforth. So you have to be familiar as and when the word is told. You should imagine, and you should really, the definition should be elaborated in your mind so that you are following it properly. Okay, next. As I told you, in heart failure, what all can happen? In heart failure, there is a reduced cardiac output, which reduces carotid sinus discharge, and hence there is increased sympathetic flow, which causes increase in heart rate as well as contractility to compensate. On the other hand, there is reduced renal blood flow, which will increase the renal release, and hence once that is released, angiotensin 2 is released, which is a very powerful vasoconstrictor, which is where this angiotensin 2 is mainly involved for remodeling, increasing the preload and increase the afterload. As I told you, it is a mixed vasodilator, and also noradrenaline is released. Noradrenaline acts only on alpha 1. See, you should remember this table. Adrenaline acts on all the receptors, alpha 1, alpha 2, beta 1, beta 2, whereas noradrenaline only on alpha 1, alpha 2, beta 1. Isoprenaline is selective one, non-selective beta, beta 1 and beta 2. And dopamine, which is a natural one, again, it has got, I'll show you later, in 3 different doses. It can act at 3 different sites where we use it almost for different conditions in each of the cases, where it is an IV inodilator, where it is an IV inotrope. Okay, so all these will cause in heart failure, all these compensatory mechanisms will be seen, and so we have to target at these areas so that the patient can lead quite a normal life and hence be done with it in most of the cases. So these are the few things what you have to remember in further going to the heart failure and seeing to it what are the mechanisms what we see and hence what we know about many of these things. Now, drugs used in heart failure. Whenever the patient comes with great pain and also to decrease the pulmonary edema, both the things we use morphine. So how does it reduce pain? It acts as a mu agonist, reduces sleep, indifference to the surroundings. So pain, and because of these 4 mechanisms, it relieves pain and anxiety. Regarding relief of acute pulmonary edema, it is the same action as furosemide. It will shift the fluid from the pulmonary to the systemic circulation, so that the lungs are free and it is only filled with air. Next in order is vasodilators, and if there are signs of congestion and BP are maintained, then BP should be maintained here, where only then we can use these drugs, nitrate, sodium nitroprusside and neziretide. Otherwise, you have to be very careful because these are the drugs which will decrease further the BP and hence might cause death also. So we have to be careful and monitor BP and then start with these drugs. Next, diuretics for fluid retention, where with strategies against diuretic resistance are also seen. So you have to check the electrolytes, because all mostly there is furosemide. Loop diuretics are known to cause 3 types of toxicities. One is electrolyte imbalance, that is all hypo. You remember hypo, you will get the answer. Hypokalemia, hyponatremia, hypochloremia, hypomagnesemia, and hypocalcemia. And second is metabolic adverse effects, that is hyperglycemia and hyperuricemia. And thirdly, organ toxicities, ototoxicity, as well as nephrotoxicity. So these are the problems which are met. So you have to be really aware of this while adding these, and hence we can have, because of toxicities or because of increase in dose, we can have diuretic resistance. Then we can use combination of diuretics and hence sequential blockade also at times. Then if there is any cardiogenic shock, then we use with oliguria, we add dopamine, and we have to reduce the AC inhibitor dose at this junction when we add diuretics. We can use aquaretics for hyponatremia, that is vasopressin 2 antagonists at times. The mainstay in acute failure is also inotropes. Whenever there is a hypoperfusion, most of the times we find these things, patient going on to cardiogenic shock. We use these drugs, dopamine, dobutamine, and phosphodiesterase inhibitors, including levosimendan, but not epinephrine. Though some studies have shown all these sympathomimetic agents, they increase all the actions of the heart. Once they increase all the actions of the heart, the coronary flow is decreased. So once the coronary flow is decreased, the blood supply to the heart is decreased. So it is skeptical to use these sympathomimetic agents, but we should use these inotropes which cause increased force of contraction and hence does not alter the heart rate. So the coronary flow is also maintained. And so to say, the heart comes back to the normal physiological shape as much as possible by these drugs. Next, vasopressin directly for septic shock and during CPR as well as intraoperative hypotension. In these cases, we use this vasopressin. Role of BP and drug choice in severe hypotension, as I told you, dopamine in higher doses, 5 to 20 micrograms per kg per minute. But now norepinephrine is the choice of each of the physicians, where it acts only on alpha 1, alpha 2, and beta 1. Dopamine in higher doses is acting on alpha 1, especially only for BP and hypotension, whereas in moderate doses, it acts on the heart as well as kidneys, where we normally use in patients with congestive cardiac failure and cardiogenic shock. Modest hypotension, any vasodilator like sodium nitroprusside or phosphodiesterase inhibitors or dobutamine. The difference between dopamine and dobutamine is dopamine works only in cardiogenic shock because it does not have any action on the kidneys, whereas dopamine acts on hypotensive shock with oliguria. With oliguria also it acts. So that is the advantage. So the indication for dopamine is always the cardiac failure with cardiogenic shock, whereas this one, dobutamine, is only plain cardiogenic shock, the urine output being maintained, the urine output being maintained at 30 ml per hour, 30 ml per hour, or you just put the catheter and see how good these urine flow is there, then decide between these two drugs. BP above 100, you can definitely use nitroglycerin IV or nesiritide or nitroprusside according to the situation. And I hope all of you know the actions of nitroglycerin, which we saw it in nitrates, then the nitroprusside. All these have been dealt already. Nitroprusside is an IV administered vasodilator, which dilates both arteries and veins. And also this nitroprusside will it should be wrapped in a black paper because it gets oxidized, and this should be given for about 72 hours because there might be sudden rebound hypertension if stopped suddenly, and if you don't monitor it may go to hypotension also. So you have to monitor it for 72 hours. Next, I'll go on speaking all the drugs with related to heart failure only, though it has many effects in pharmacology. We will restrict ourselves to heart failure, except furosemide. Furosemide is a loop diuretic. Furosemide is a loop diuretic. Morphine is an opioid analgesic. Aminophylline is a bronchodilator, which is a theophylline derivative. Furosemide, all these three are used in acute heart failure. Furosemide to decrease pulmonary edema, increase the renal blood flow, and hence urinary output. Morphine mainly for pulmonary edema and also pain. Aminophylline to differentiate between cardiac asthma and bronchial asthma. So in both the things, this aminophylline can be given, and it is a very good drug, but nowadays we don't use it. So all these are administered by IV infusion. I hope all of you know the difference between infusion or a drip and a bolus or a stat. Bolus or a stat is you just take it out from the ampule or the vial and push it and be done with it. Whereas infusion or drip can be from seconds to minutes to hours to days to years to months to days to years. So it can go till that level, and these drug IV loading dose is given in case of inamrinone, milrinone, and levosimendan, which are phosphodiesterase inhibitors, and also these amrinone and milrinone will increase the cardiac contractility. So these are the ones where levosimendan is a calcium sensitizer, and inamrinone and milrinone is a phosphodiesterase inhibitor. So these will increase the cyclic AMP level, increase the calcium level, and hence increase the contractility. So they are used as IV infusion preceding the IV loading, preceded by IV loading dose, whereas the first three are given only by IV infusion. Development of tolerance limits the usefulness of the last three drugs in heart failure. So they are used only for short-term control because of tolerance on prolonged use, and they have to be used by continuous IV infusion, hospitalization, cost, its own problems, etc. Now, a word about sodium nitroprusside is a mixed vasodilator, no significant positive inotropic effect. That is a contractility. In comparison to sodium nitroprusside, dobutamine is a good positive inotropic activity and no vasodilatation. It is the reverse. So, in case of cardio, where the cardia is at the problem, dobutamine. If the blood pressure is at a problem, then it is sodium nitroprusside. Along with this, we have PDE3 inhibitors, which have got positive inotropic and peripheral vasodilatation. So they are known as inodilators. Ino is inotropic, dilatation is peripheral vasodilatation. Two things work in favor of whenever the patient is heart failure. So these are the three drugs which are used in amrinone, milrinone, and levosimendan, where it has been used as PDE3 inhibitors and more effective than sodium nitroprusside and dobutamine for short-term acute heart failure. For short-term acute heart failure, as they have to be given continuously and monitored, and also development of tolerance. The inotropic agents mainly increase the force of contraction without proportionately increasing the heart rate. The main drugs are dobutamine and dopamine. Adrenaline and isoprenaline should not be used as said before. Adrenaline on alpha 1, alpha 2, beta 1, beta 2 receptors, isoprenaline only on beta 1, beta 2. There is no doubt that isoprenaline increases the heart rate, and the patient may even complain that heart is coming to mouth and say that thumping of the heart is there. So, such is the effect of isoprenaline and adrenaline. So, it should not be used because they increase all the actions of the heart except the coronary flow, where we want a good coronary flow also, where it will not be there. So patient can die even of MI and arrhythmias when these drugs are used. Chronic inotropic therapy, we do not have any such thing apart from acute situations, that is in amrinone, milrinone, and dobutamine. And even used for a longer term, they increase mortality, except or the exception being only digoxin. But that has been put to the last of the cardiac failure because we have got very effective anti-mortality drugs nowadays where the patient can lead a good quality of life and he can go to his own work and be done with it, and without any support he can lead a normal life also. So we have got such good anti-mortality drugs now. Digoxin will not cause mortality, but will not decrease morbidity also. So we have to be skeptical about these things and see to it that only when in resistant cases, when all the drugs are over, only God can save, then you can just administer digoxin. Now, I'll try to explain a little bit of these things so that you will understand to a great extent than just telling orally. Okay? Okay. So here, hmm. See, you are seeing these, this is the effect of catecholamines. Catecholamines are mainly four: epinephrine, norepinephrine, dobutamine, and dopamine. Of these, dobutamine is synthetic, the three are natural. Isoprenaline is also synthetic in nature. Now, dopamine acts at three doses: the lowest dose on beta 1, beta 2 receptors, the moderate dose on DA1, DA2 apart from beta 1, beta 2, and the highest dose on alpha. Dobutamine acts mainly on beta 1, that is mainly on the heart. Norepinephrine, beta 1 more than alpha, more than beta 2, but mainly causes vasoconstriction and inotropic effects. And epinephrine has got beta 1 equals beta 2, which is greater than alpha. Beta 1 effects on the heart is horrible. So you have to look upon these, and alpha vasoconstriction also is quite harmful. So now what are the effects? So because this acts only on beta 1, we want inotropic vasodilatory effect. Inotropic vasodilatory effect. So we use it mainly in cardiogenic shock only. Whereas dopamine acts on the renals because of peripheral vasodilatation acting on DA1, DA2, increases renal blood flow, increases renal output, also acts on beta 1. So it is using cardiogenic shock with oliguria. Okay, the lowest dose causes vasodilatation. So we are not bothered to that extent. So we are very happy with lowest doses. We don't use it at all. Moderate doses, we definitely use it in cardiogenic shock with oliguria because it has got action on the kidneys, and the alpha action is at the highest dose. So we use it in hypotensive shock, but we prefer norepinephrine to dopamine in case of hypotensive shock or hypotension due to septic shock. Norepinephrine mainly is alpha action, vasoconstriction, increases blood pressure, but to a certain extent it is also an inotropic. But both inotropy as well as vasoconstriction is not needed many times except in septic shock. So in such cases we try to use it. This is both inotropic dilator and constrictor. This constrictor is a big problem. So for this reason we try not to use epinephrine at any instances. Now, as I told you in the previous slides, I'll show you three different doses of dopamine where we can use it at three different places in acute setup or in MICU. 2 to 5 milligrams per kg per minute. This is all you should had these. It's all by dopamine by IV infusion, never by IV drip. Always given parenterally, expressed in micrograms. See, all drugs can be expressed right from micrograms to milligrams to kgs to tons, okay, to units. So all these will come in your dosing schedule. So you please be careful. If at all the patient gives 2 to 5 milligrams, then it is a havoc. So you should be very careful. See the label before taking out the drug, and you should not leave it for the nurse to do the rest of the job. So 2 to 5 micrograms per kg per minute. You should calculate that according to the body weight, and renal and mesenteric dopamine receptors are stimulated. It causes vasodilatation. As such, there is enough of vasodilatation. So most often we do not use this unless until there is a very profound increase in blood pressure. This is the main dose what we are using day in and day out, 5 to 10 micrograms per kg per minute. Mainly acts on cardiac beta 1 receptors, causes positive inotropic action with little chronotropic action. That means force of contraction is increased without increasing the both the automaticity as well as the conductivity. Lastly, 10 to 20 micrograms per kg per minute acts on vascular alpha receptors. Alpha receptors stimulation causes increased vascular resistance and increases blood pressure. So hence, because of this vasoconstriction, rise in blood pressure, we normally use it in hypotension. Now, what is the role of vasopressin in heart failure? Okay, so we have V1. We have two receptors of these. We have V1 agonists for selected types of heart failure, and V2 antagonists for aquaporin inhibition and vasodilatation, most often in chronic heart failure. So here you can see that this is secreted by the hypothalamus, which will act on the distal convoluted tubule on the collecting duct, where we have got 5 components in the distal convoluted more than distal collecting duct. We have 5 components where it is interacting. One is aldosterone, second PTH, third aquaporins, fourth fourth is potassium, directly acting channels, and fifth is these are the 4 main things which act on collecting ducts, one of them being the vasopressins, and here they get inhibited by V2 receptors when they act, and hence we can use tolvaptan in hyponatremia cases where the patient will not eat. First of all, we would have told in hypertension, don't take salt. We would have told lessen salt, they would have stopped salt. So as age increases, the sodium content retainment is decreased and sodium transfer to the brain is decreased. So hyponatremia results, and patient can really sit and sleep, and giving these saline things every minute with water will increase his power of the brain within about 2 hours just by orally. You need not take them to hospital also. So in hyponatremia will be great when we add multiple drugs in heart failure. So in such cases, we can add tolvaptan where we can be done with it. In acute failure, we add conivaptan, which causes vasodilatation because of vasoconstriction, septic shock. In such cases, vasodilatory effect is needed, and hence we want this conivaptan. And therapy, especially in deficiency, we use this vasopressin, where it acts on V1 and increases the vasoconstriction, especially in septic shock. This is inotropic dilators. Inotropic dilators or inodilators, they increase the cyclic adenosine monophosphate cyclic AMP in vascular smooth muscles as well as in myocardium. So when they increase the vascular smooth muscles, vasodilatation occurs, and in the myocardium, when this is increased, it increases the inotropic, chronotropic effect and also causes arrhythmogenic effect. So arterial dilatation, the increased cyclic AMP is seen mainly with amiodarone, milrinone, and inoxamone, where they inhibit PDE and inhibit cyclic AMP, and increases the cyclic AMP and calcium calmodulin complex and causes the dilatation. Whereas in the cardiac myocytes, here you see that there is blockade of this calcium through cyclic AMP, where it increases this and causes myocardial contractility because of cyclic AMP, because they are producing inotropic effect with vasodilatation. They are known as inodilators. Now, the role of nitric oxide, endothelium, and cyclic AMP, and hence necessary. So, nitric oxide, as all of you know, it is present in the vascular tissues, and the main physiological action is always vasodilatation, where we are very happy with that, both physiologically as well as pathologically. Now, necessary is a physiological component where this acts on nitric oxide in the same way as nitrates, and hence will act on guanylate phosphate, increases cyclic AMP, and also can cause cyclic GMP, and so it can relate to these effects, where when we block this, we will have, when we increase these necessary components, we will decrease the hypertrophy and failure of these drugs. The other one is sildenafil, which is a phosphodiesterase inhibitor, PDE5 inhibitor, which will act on cyclic GMP and hence will inhibit the calcium, causing vasodilatation and also in cardiac hypertrophy as well as failure. Now, based on mechanism, you have to know certain of these drugs, what are being used today and what are the recent ones which are being used today. Diuretics, mainly we use furosemide on acute basis, torsemide on chronic therapy, thiazides combined with AC inhibitors, most often very small amount, 12.5 or 6.25 of hydrochlorothiazide in elderly, chlorthalidone, because it is long-acting, once daily administration. And potassium sparing diuretics or mineralocorticoid receptor antagonists, that is aldosterone antagonists, are used whenever there is resistance, but you have to note the potassium level, it should not be more than 4.5. In such cases, we add spironolactone, which will decrease the fibrosis as well as hypertrophy, and which is more advantageous. Next is vasodilators, that is AC inhibitors. Amongst this, normally we use ramipril rather than these three. Captopril no more used because of dysgeusia. Enalapril and lisinopril, ramipril has got more studies, more trials than these, and so ramipril is a drug of choice as a vasodilator, which decreases mainly the preload and then afterwards the afterload. If not tolerated due to dry brassy cough only, that is the main problem with AC inhibitors. In such cases, we add ARBs, losartan, telmisartan, as well as azelastine, and also sometimes valsartan also. The recent one, whenever the symptoms are there, but the patient is maintaining with the drugs, but still the symptoms are there, to increase the survival benefit, we are using nowadays ARBs with NEP, neprilysin inhibitor. There's a combination of valsartan and sacubitril, which we'll come to it later. Next, we are using nitrovasodilator, sodium nitroprusside, glycerine trinitrate, as well as acetaldehyde in acute conditions. Endothelin receptor blockers, mainly in pulmonary hypertension. Most often we use our pulmonary pressure being altered, then we use bosentan as well as abrisentan nowadays. Even in pulmonary hypertension, we are using sildenafil. Direct vasodilators, hydralazine, but fear of SLE. It is a potassium channel opener, but fear of SLE. Most often we give IV, used in acute. Calcium channel blockers, amlodipine, provided the heart rate is normal, we use amlodipine or felodipine. We use amlodipine because it is long acting. Why? How it is long acting? Because it will have more plasma protein bound entity. Once the drug is plasma protein bound, always it is a long acting drug, because plasma protein bound entity is a stored one. It does not have any action. Slowly it gets released as the free drug is metabolized, or it is totally excreted. Slowly the drug is released, and hence amlodipine becomes a longer acting one. But we have to be fearing about edema as well as gingival hyperplasia. Beta blockers are the mainstay in heart failure, which was once upon a time, about 3 decades ago, it was contraindicated in CCF, but now it is the drug in heart failure because of other reasons also. Though it decreases the force of contraction, the main thing is, on a long run, it will act to decrease the hypertrophy as well as apoptosis. So for that reason, we use beta blockers. The first drug of choice is carvedilol, then metoprolol succinate, not tartarate. Metoprolol succinate is used because we have found that with tartarate, mortality has increased, maybe because of dosage forms also. Bisoprolol and nebivolol are beta 1 with nitric oxide activity, which causes vasodilatation, and hence there is decreased maintaining the blood pressure also, and together with that decreasing the heart rate also. Sodium potassium ATPase inhibitor, that is the cardiac glycoside digoxin, is the last drug of choice, which does not increase or which does not affect mortality, but it will affect the morbidity. So we have put it in the last, and we have other features also why digoxin has come to the last place. Inotropic agents, again I repeat, dopamine, dopamine, and dopexamine, and PDE3 inhibitors, inamrinone, milrinone, and levosimendan. The other miscellaneous drugs are istroxamine, morphine, as well as aminophylline. Now, coming to each of the drugs, their rational use. See, every time you should know the rational use and the time of administration mainly. Otherwise, what happens? The physiological activity will be at one time, and you will be putting the drug at the other time. Okay. Now, see, that is known as chronopharmacology. See, for example, all these statins are administered at night. Why not in the morning? Is it that the person is very free in the evening? No, because HMG-CoA reductase enzyme is very active at about between 10 to 12 p.m. at night. This is the problem, and hence we administer statins at night. Because we should be very active, we want corticosteroids as well as beta 1 stimulation, that is maximum in the morning. So there you can see that corticosteroids will increase, that is an physiological antagonist to insulin, can increase blood sugar, and heart rate increases. There might be chances of MI, so you have to block it. So you give the drugs in the morning. So accordingly, you have to see. And RAS activation is most often there at night than in the morning. So always start these SE inhibitors and ARBs at night. Only when the dose has increased, you shift it to morning. Otherwise, always give it at night, because you are seeing that RAS activation is also blocked, one, and you are preventing the adverse effects, mainly the first dose hypotension, because the patient will sleep, half of the drug would have got excreted by morning, and so patient is quite safe. And nowadays you see that all of them are all alone, looking at the walls of their house and staying all alone at home. We don't know what will happen, when it will happen. God only knows. So as doctors, we have to do our duty. So you should know about chronopharmacology, the time of administration of drugs. For that, you should know physiology, when which system is active at which part of the day. Accordingly, you block those areas, you will have good effect. And even with lowest doses, with little bit of counseling, the patient can be without adverse effects and lead a successful, good quality of life. Now, coming to the rationale of using AC inhibitors in CCF, as all of you know, AC inhibitors and ARBs, AC inhibitors decrease the formation of angiotensin 2, and ARBs will block AT2 receptors. Both of them will decrease aldosterone, where sodium and water retention will not be there, but potassium retention will be there. It increases bradykinin levels. This is the problem. So once bradykinin levels are increased, there can be bronchospasm. There can be bronchospasm as well as vasodilatation, which can lead on to further, hypotension and further after effects. Because it's a mixed vasodilator, you see that afterload and preload are decreased, and because of that aldosterone and increase in blood flow to the kidneys, you have decreased plasma volume. All these effects put together, the blood flow to the heart is decreased, so it can reverse ventricular hypertrophy as well as renal cardiac remodeling, and also the stretching of fibers can be decreased to a very great extent. Because of these effects, the myocardial workload is decreased, cardiac output is moderately increased, and flow to the coronaries is increased, the heart rate is decreased. So indirect anti-HNL effect, indirect anti-arrhythmic effect, and because of moderate increase in cardiac output, the systolic and diastolic BP can be maintained to a certain level. Because it reverses these hypertrophy, cardiac remodeling, apoptosis, as well as fibrosis, there will be a prolonged survival and a good quality of life. A few important points. We use eprillinone nowadays than spironolactone. Both of them are mineralocorticoid receptor antagonists, where this eprillinone has got less estrogenic side effects, whereas spironolactone has got lot of anti-androgenic effects. And so we are more bothered. Instead of that, we can use eprillinone. Start beta blockers with a low dose and titrate to achieve maximum response, as significant response occurs only after few months of treatment, not an immediate effect. So in any case, you should not use it for immediate purpose. We should use it for long-term treatment for decrease in mortality and survival benefit. The beneficial effect of chronic treatment is due to the effect on myocardial function and not due to direct hemodynamic effect. What do you understand by this? Myocardial function means the decreased force of contraction is the one which will really give the benefit effect of beta blockers, and not that decrease in BP or renin activity, etc., etc. This is not the main reason. This is the reason in heart failure how it works. ACE, ARB, and beta blockers slows cardiac remodeling, reduces the progression of the heart failure, increases the cardiac output, and also increases the cerebral rate. That is why these are the in case of heart failure. All of you know, no, you should start with AC inhibitors, ARBs, mixed vasodilators, preload, afterload, left ventricular end diastolic pressure, volume, decreased cardiac output. You should start like this. For beta blocker, decreased heart rate, decreased cardiac output. So left ventricular end diastolic time and pressure is increased, diastolic time is increased, cardiac coronary flow is increased, cardiac output is decreased, systole is decreased over a period of 3 weeks, and then BP decreases. That's why we don't use it acutely, and it is not the first drug of choice in hypertension. It is used only in hypertension with other cardiovascular disease, the cardiovascular condition, not per se. This is again in combination. I have just shown to reinforce you people how these things work. Mechanism of drug action of some drugs. Diuretics, how do they act? We use either furosemide or thiazides or hydrochlorothiazide, as well as chlorthalidone. The only difference is this acts on loop of Henle, blocks the symporter mechanism of sodium, chloride, potassium to co-transporter and symporter mechanism in the loop of Henle, whereas thiazides will block at the distal convoluted tubule sodium and chloride mechanisms. So they decrease salt and water, increase the salt and water excretion, so decreases the plasma volume. Vasodilators, they decrease the venular dilators decrease venous return. Once the blood flow to the heart is decreased, preload is decreased. Once preload is decreased, myocardial workload is decreased. So this is the main area what we see, and hence there is decrease in force of contraction. And arteriolar dilators, they decrease the peripheral vascular resistance and hence increase the outflow. That is, the flow from the heart to the vessels are decreased and hence decreases the load. And these inotropes mainly are digoxin, beta agonists, and PD inhibitors. They increase the force of contraction without increasing the heart rate, So they are useful in heart failure. And beta blockers, they decrease sympathomimetic activity and decrease cardiac output. So in one slide, you can see what are the main drugs, the anti-mortality drugs in CHF, and see to it that you can really be done with it. You can prevent and also effectively treat, if at all you know the principles of using these drugs, when, where, how, why, what. Now, a little more in detail about these various vasodilators. Both preload and afterloads are decreased by nitroprusside, which is a nitric oxide donor. which is given only by IV drip, not by IV bolus, and it is acts mainly through nitric oxide. Nitric oxide is known to cause vasodilatation, and so mainly in the vessels. So mainly we prefer it in hypertension and emergency heart failure, where BP is decreased to the increased to the maximum extent. The other drug is phentolamine, which is a non-selective alpha blocker acting on alpha 1 and alpha 2 receptors. This also, because of that alpha 1, alpha 2 mechanism, it decreases both preload and afterload. So used in emergency hypertension as well as in pheochromocytoma, which is an adrenaline, which is an adrenergic tumor. Moderate reduction in both preload and afterload, which is the mainstay in heart failure. AC inhibitors, ARBs, and PDE inhibitors, milrinone, amrinone, only by IV emergency. Beta 1 and alpha 1 blocker, both carvedilol and labetalol, can be used in all these cases. Predominantly reducing preload are only venodilators. They are only nitrates. Nitrates, prazosin, diazoxide, minoxidil, and hydralazine. So hydralazine, minoxidil, diazoxide only by IV, and because of their adverse effects, we are not using. Prazosin will cause first dose hypotension, so we normally use as the last drug of choice after ABCD drugs in hypertension, that is the resistant hypertension. We do not use it in heart failure, but we use GTN in heart failure. As GTN, we use it sublingually, and as nitroglycerin IV, we use it both in emergency heart failure. In angina, we use it as GTN sublingually. In hypertension, as a last drug of choice, we use only in hypertension, emergency hypertension, and emergency heart failure as IV nitroglycerin. Then predominantly, which reduces afterload, as I told you, minoxidil, hydralazine, nifedipine. These drugs, they are potassium channel openers, direct vasodilators, again potassium channel openers, hydralazine, and nifedipine, which is a dihydropyridine, which belongs to calcium channel blocker, which acts on L-type calcium channels on the arterial blood vessels. So in order of choice, it is used in hypertension, angina, never in heart failure because it causes tachycardia, but in combination with beta blockers, you can afford to use it. So how do we use, or how do we come to a conclusion that which drugs can be used in conditions where in chronic heart failure according to NYHA classes? I hope all of you know what is NYHA. In stage 1, no symptoms, nothing is there. Repeatedly keep on checking so that patient does not go effectively control hypertension, reduce salt intake, good walking, lifestyle modifications. If any other alterations is there, obesity, etc., all these should be decreased. Now, but start on AC inhibitors because they are cardiorenoprotective. Cardiorenoprotective. So because of this, because they dilate the blood vessels in the nephrons, increase the kidney flow, and in the heart, they will decrease all the effects and also decrease the fibrosis, apoptosis, as well as remodeling. So these are the advantages. Because of these drugs, if instituted early, patient will never go to heart failure at all. Then if edema starts, then add diuretics, where we can use a sequential nephron blockade. What do you mean by this? Sequential nephron blockade means one after the other it should block. For example, loop diuretics with thiazides with spironolactone. All three when used together, they are known as sequential nephron block. Please find out, are there any other sequential blockades in medicine? Any other sequential blockade in medicine? You have got 2, 3 more. So you find out which are those sequential blockades, which we can revise it in the next class if you remind. Next, beta blockers, mainly metoprolol, carvedilol are the drugs which are used here, and all these three put together. Diuretics, especially mineralocorticoid receptor antagonists, AC inhibitors, ARBs, beta blockers, all these three put together are known as anti-mortality drugs. So this is one of the common questions. Name anti-mortality drugs along with rationale. So you have to know what all should be done. See, with AC inhibitors, though it blocks formation of angiotensin 2, there is escape. That's why even if we put them on AC inhibitors, ARBs for a long time, patient can go to further renal failure and cardiac failure in the last stages. So because of that, we have started using this ARNI nowadays. Okay, so there is aldosterone escape in case of these drugs when it is put constantly. So you should know what is aldosterone escape and why that occurs very commonly. All these three put together, that is AC inhibitors, ARBs or ARBs, diuretics, especially MRA, mineral corticoid receptor antagonists, and beta blockers. All these three put together are called as anti-mortality drugs in heart failure. Aldosterone blockers, same, that is spironolactone and epinephrine. We choose epinephrine than spironolactone because of its adverse effects on androgens. ARBs and ACBs, ACE should not be combined together because of profound hyperkalemia and hypotension. We should be very, very careful. Only in certain renal failure patients we use, and in certain trials we have seen that there is a very small benefit. But as far as possible, do not combine ARB with ACB and with especially aldosterone antagonists, because there will be very severe hyperkalemia, which can go on to arrhythmias and whatnot. The last drug of choice is digoxin when they go for stage 3 and beyond that, because of its narrow margin of safety, lower therapeutic index, accumulation, all these problems, monitoring, all and giving drug holiday, all these are the problems which are met. And so we do not try to use digoxin unless until it is warranted. Lastly, if affordability is there, we can go for CRT as well as BB by B pacing also. This is once you start the therapy till where you can give maximal therapy for severe CCF. Severe CCF, first of all, lifestyle modifications, dietary sodium, water, sodium mainly less than 2000 milligrams per day, water restriction to about 1 liter. Then we start off with we start off with we, it stimulate the renin angio also activates the system. So we use RAS blockade and beta blockade. Okay, and then low blood pressure with decreased renal perfusion by reflex beta adrenergic baroreceptor activation. Vasoconstriction results from formation of angiotensin 2 and blockade. ARBs, integral part of the therapy as are beta blockers. Then aldosterone are also essential, but in resistant cases, we have seen benefit of nitrate and hydralazine combined together because they are one is a venodilator, one is an arterial vasodilator. So both put together, there is a good benefit what we see in all these cases. The in case of in case of resistant disease, resistant people, we start using this perhexylene, CRT, digoxin, LV assistant transplant, and stem cell therapy. Here in these cases, we see that if there is any edema, peripheral edema, that can be solved by diuretics. In lung edema, by furosemide or even torsemide, sometimes orally when there is a very minimal. Diuretics, which will decrease the blood volume, and hydrochlorothiazide has got a vasodilatory effect on a long-term cases, with lowest dose are 6.25 or even 12.5 milligrams. And ACE and inhibitors, ARBs, and as well as aldosterone blockade causes vasodilatation and hence beneficial effects on the heart. This is the step up and the maximal therapy what we give it in severe CHF. So stage by stage, the same thing again I have repeated here. The risk factors for this one should be taken care of. Prevention of HF by therapy of risk factors. All these should be treated. All these should be taken care and treated. Stage B, there is already structural heart disease. Prevention of neurohumoral activation. How? By AC inhibitors and beta blockers. So these are the two main drugs in cardiovascular conditions. Wherever you go, whatever you do, if you happen to administer AC ARVs, that means God has given you 9 ideas. Okay, God is in front of you. God has helped you to a large extent, and so you are seeing that the patients are very, very safe in your hands once you start with AC inhibitors or ARBs. And if tachycardia is there, beta blocker in hypertensive per se itself, so that you are not going to this stage B at all if these two, the first two, are taken care of. Stage C, there is clinical symptoms and signs, fluid retention, pleural effusion, pulmonary edema, milder pulmonary edema, then paroxysmal nocturnal dyspnea. All things will start. So here you have to start with diuretics, aldosterone blocker, because it will help in hypertrophy and fibrosis. Then increase to maximum therapy uh, as much as possible. Stage D is end stage, where we try to be with inotropic infusions and start with digoxin also, so that it will increase the inotropic effect, but the heart rate is not increased, and also it will increase the urine flow. Because of these small benefits, we try to use digoxin at the third or the fourth stage. In case of chronic heart failure, drugs that reduce mortality, improve symptoms, and might harm. See, these are the drugs known as anti-mortality drugs. The fourth one you leave off. Okay, these three. Even in your dreams, you should be able to say these three are the anti-mortality drugs. If anybody has not administered, you just closing your eyes, you administer, so that you are saving the patient as much as possible. Okay, and according to the clinical judgment, that means edema, diuretics. Digoxin if the symptoms are still persisting after these drugs. Nitrate, same thing if there is edema and the blood pressure has not decreased. Most often patient will go off to anemia, so you can give drugs chronically also, or you can give, nowadays we have got carboxy maltase, which is given by a single IV infusion. So you can repeat every 1 or 2 months, so that the patient is good in anemia. If at all there is further anemia, it goes on to high output failure. So for that reason, you have to be careful. Metabolically active drugs are considered when these are resistant, completely resistant, and the drugs are trimetazidine, ranolazine, and ivabradine, and sometimes nicorandin also. So these drugs should be only in case of exceptions, and also in emergencies. Inotropes and inotropic dilators, antiarrhythmics, don't use beta blockers and amiodarone. Others can be used. Calcium channel blockers, don't use verapamil, diltiazem. Others, see to it that you are using in combination. High dose digoxin, which was previously acceptable, but now no, because they go on to digoxin induced cardiac toxicity, which we will be seeing it later. Okay, so because of these reasons, you have to know this. Now, coming to digoxin, 2 or 3 slides. These are the things which you should really be, which you should have at the tip of your fingers. Digoxin bioavailability varies from manufacturer to manufacturer. So you have to stick on to the same brand and same dosage. If at all you change the brand, patient was all right, will come and get admitted in a casualty, because the therapeutic concentration would have increased. Patient would have gone on to dioxin-induced toxicity. So these are the problems. So keep on calling them. We have a view on them and see to it that the brand also remains the same and dosage also remains the same. Otherwise, you compare it and see that you are in touch with the patient, so that no toxicity will occur. So either toxicity can occur or therapeutic failure can occur because of low therapeutic index and narrow margin of safety. So because of this, though we are giving loading dose and then maintenance dose, everybody can't do therapeutic drug monitoring. So the most commonest one, how to see that the concentration is maintained in the body, by 2 methods. One is therapeutic drug concentration, where we will get it done from outside, which costs about 1,500 every time, so patient cannot afford it. The second type is giving a drug holiday. So Sunday is a holiday for you, so give holiday to the drug also, so that the concentration comes back almost to near normal by Monday. So with that and clinical signs and symptoms, you can make out whether the patient has is in the normal steady state plasma concentration, not going on to toxicity, digoxin-induced toxicity. This is the mechanism of action of cardiac glycosides. Normally, what is happening in the cardiac cells? Sodium is inside. Sodium entry occurs. Okay. See, sodium entry occurs. This will go with sodium calcium exchanger. and hence calcium also enters. This will act on the sarcoplasmic reticulum, which will act on troponin, actin myosin kinase, and hence contraction is going to occur. This is the normal one. Now, what has happened because of heart failure? These are not working. So, what happens? Sodium potassium ATPase is working to a great extent. So you block this enzyme. Once you block this enzyme, what happens? Whatever sodium has entered will get exchanged. This will not occur. So potassium will remain outside. Sodium will be inner. So sodium will draw calcium along with sarcoplasmic reticulum, will increase troponin, and hence contraction will take place. Here I have written it directly. So they inhibit sodium pump in the cardiac cells. Accumulation of sodium prevents extrusion of calcium by this mechanism, and so increased entry of calcium into the cell, where intracellular calcium increases, stored in sarcoplasmic reticulum, which will increase the calcium during each contraction, and hence force and velocity of the contraction is increased. Okay, this is not only the advantage but also disadvantage, which I'll tell you later. The advantage is it is used in CCF because of this action, mainly because of this action, and because it inhibits the sodium potassium ATPase enzyme or the pump. Okay, increase in calcium level and contraction, and inhibiting sodium potassium ATPase increases force and velocity of contraction, and hence increases the contraction, and hence useful in CCA. This is the same thing what I have depicted to you to reinforce it. I have shown you, that's all, nothing more than that. See here, it is exchange sodium pump. Okay, so for 3 sodiums, 1 calcium will go out. So when you are blocking, what is happening? More of calcium is retained along with sodium, which increases the contraction. And this calcium homeostasis is very important. This is the one which causes both therapeutic activity as well as toxicity. Increase in calcium contraction causes inotropic effect. Sodium potassium ATPase inhibition, calcium increase will increase the positive inotropic effect. That is the result of adding digoxin. But when digoxin is continuously added, this is totally blocked. Potassium will never enter. So what happens? Calcium is accumulated. Once calcium is accumulated, what happens? It will act on the ryanodine receptors, and hence what happens? Intracellular stores are very much increased and intracellularly, and this results. This will combine with troponin C, which will have a drug interaction and increases the actin myosin kinase reactions, and results in contraction of the myocardial muscle continuously, and results in digoxin induced both atrial as well as ventricular arrhythmias. Now, what are the effects of inotropic, vagal, and sympathetic effects of digoxin? Inotropic effects are what? Increased force of contraction. Increased force of contraction. Vagus, as I told you, vagus is inhibitory to the heart. So, digoxin is vagomimetic. Vagomimetic. So, once vagus is stimulated, the SCA node is suppressed because vagus is depressant to the heart. So, it will suppress the action on the SCA node to AV node, and hence decreases the heart rate, which is the principal mechanism what we use it in case of atrial arrhythmias. And sympathetic effects, that is beta 1 as well as dopamine, sodium potassium ATPase pump is blocked, and so once this is blocked, what happens? Calcium increases, which increases the force of contraction. So as you know, adrenergic activation is there, RAS activation is there, aldosterone activation is there, and baroreceptor activation is there, where all these are the blocking effects of digoxin, where you see the maximum benefit seen, but because of its narrow margin of safety, therapeutic window is very small. Drug holiday should be given, monitoring should be done, loading dose and maintenance should be given. All these are the problems which are met, and so digoxin has gone to the last step in case of heart failure. Now, coming to toxicity, as I told you, I've already explained to you calcium overload. This calcium should finish it off here only, but before that, because calcium is more, one more repolarization will take place before phase 4. So that is delayed after depolarization, which will give rise to one more action potential before going on to the rest stage. And so for that reason, there will be a tachycardia first, that is bigeminy. What do you mean by bigeminy? Normally, heart should beat like one Shatabdi Express. Dug, 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 dug. But with bigeminy, what happens? Dug, 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 dug. That is bigeminy, where one beat will escape. So there will be ventricular bigeminy, then arrhythmias, then lastly there will be ventricular arrhythmias totally. And because simultaneously it is stimulating vagus also, it can go to bradycardia. So in a flow diagram form, what you do is digoxin toxicity, put two things. It is cardiac, non-cardiac. In non-cardiac, it causes nausea, vomiting, and halos. Because nausea, vomiting, because vagus is stimulated to the stomach. And here in cardiac, you have atrial and ventricular. In atrial, it can produce, because of vagus block, because of calcium increase, it can produce atrial arrhythmias. What's the treatment for block? It is either for block, it is either atropine or isopranaline. Looking at what is the actual pathology. Whereas for atrial arrhythmias, the 4 heart rate lowering agents in order of choice are metoprolol, second verapamil, third digoxin, fourth ivabradine. Why that choice? You should know the reason. Why those it is in this order of choice only. Don't alter it, because you will land up in more of the side effects, which you should know specific. Don't say nausea, vomiting, diarrhea. It is not at all encountered. So you have to know the specific problems met with these. And so in order of choice, 4 heart rate lowering agents in this world are metoprolol, verapamil, digoxin, ivabradine. Or you can make metoprolol, verapamil, ivabradine, lastly digoxin. So this is the formation of digoxin toxicity. For atrial block, you use either atropine or isopranaline. Whereas for atrial arrhythmias, you use these 4 heart rate lowering agents. Whereas for ventricular arrhythmias, tachycardia, stop the drug and add potassium. Okay, the heart will go to the resting state, and so it will be normal. And for arrhythmias, either you use lignocaine or phenytoin. Both are sodium channel blockers. Fast channels are inhibited, so we use normally IV lignocaine for digoxin-induced arrhythmias. Phenytoin only in resistant cases, but most of the times we use only lignocaine. Now the question is, why lignocaine is not used in atrial arrhythmias? We'll find out the answer. Why lignocaine is used only for ventricular arrhythmias but not for atrial? You can even type it if you want it. Otherwise, you please see to it that you know the reason. This is one of the questions in your PGs also, as well as NEET exams also. And if at all you are too good in 4th year, this is one of the questions to score in Viva 11 out of 10. So these are the things what you should know. Where did I go? Okay, next, digoxin that enhance digoxin toxicity are diuretics. Hydrochlorothiazide with digoxin, we could normally use it. So for that, hypokalemia is produced. So you have to be very careful. Potassium decrease, calcium increase can lead on to toxicity and casualty. Never use these anti-quinidine, which is an anti-arrhythmic drug, verapamil, which is a calcium channel blocker. Used both in mainly in arrhythmias and quite rarely in hypertension, never in angina. Methyl dopa, a drug of choice in pregnancy-induced hypertension. When we use along with digoxin, it increases the digoxin levels, which reduce the digoxin levels because of decreased absorption. Obviously, digoxin is not absorbed, so we will not find the therapeutic benefit. Rifampicin, phenobarbital, or enzyme induction. Any enzyme inducers you give due to the hepatic blood flow, because the drug enters the hepatic with every blood flow, the certain amount of drug is metabolized normally also. With enzyme inducers, it is double, so therapeutic failure are quite obvious with enzyme inducers. So treatment of digoxin-induced arrhythmias, last choices, because it's very costly, anti-digoxin fab fragment is preferred. Otherwise, lignocaine is the drug of choice, occasionally phenytoin, in hypokalemia, potassium, cardiac pacing, and it may not be effective in severe intoxications, and cardioversion might worsen the digoxin-induced arrhythmias, and it should be attempted only in case of digitalis-induced ventricular arrhythmias. Otherwise, please don't venture it out. Now, what is the clinical status of digoxin? It is used both in CCF and atrial fibrillation. Why in CCF? Because of positive inotropic action, sodium potassium ATPase inhibition. and negative chronotropic and negative dromotropic. So delayed conduction, decrease, no change in heart rate, only force of contraction is increased. Because of this we are using. And also neurohumoral effects. It has got a diuretic effect also. So for that reason we are using this digoxin. We are also using in atrial fibrillation because it acts on vagus, vagomimetic, decreases the conduction and hence decreases the rate and hence protects the ventricles. The usual statement what you should remember is it prevents the bombardment of impulses from atria to ventricles and hence used in atrial fibrillation as third drug of choice because of its other problems. And digoxin is the only drug which is an inotrope agent used orally. All the others are used by IV or IV infusion. Now, these are the ones which are used nowadays very commonly. Newer advances, neutral endopeptidase that degrades ANP, BNP, 8, angiotensin 2 and bradykinin. So now we use sacubitril, which inhibits neprilysin. And this is used along with valsartan, which inhibits ANP and BMP. Once this inhibits, which causes diuresis, natriuresis, and hypotensive states, valsartan reduces vasoconstriction, sodium and water retention, and myocardial hypertrophy, which is increased by sacubitril. Which is increased if sacubitril is used all alone. So this sacubitril is a prodrug and it is metabolized by esterases, high plasma protein activity. So it's a long-acting drug and it causes hyperkalemia and impaired function tests. Cost is very high. It can be used nowadays. Most of the heart failure patients are with ORNI, which will decrease the hospitalization as well as death. And also it can be used in resistant ejection fraction cases where it is reducing constantly. So you can really be done with that when we use ARNI. So this sacubitril inhibits the breakdown of angiotensin 2. If it breaks down, what is the use? Again, angiotensin 2 is a vasoconstrictor along with aldosterone. It will increase everything. So for that reason, we are adding valsartan. So, and a switch over a period of 36 hours should be allowed. That means stop AC inhibitors on Monday, start ARNI on Thursday. So 36 hours should be there and increase this drug levels are increased with level of lithium and this is absolutely contraindicated in pregnancy with heart failure. So this is the flow diagram. See, beneficial response of atrial and B nephropeptide will decrease cardiac output, which is very good. Okay, and together with RAS. Okay, and neprilysin is the enzyme which will inhibit, which will degrade and hence vasodilatation, natriuresis, cardiac remodeling, decreased renin and aldosterone is formed. Because we are adding ARNI, that is valsartan with neprilysin inhibitor, that is sacubitril. Valsartan acts as ARB. The neprilysin inhibitor is sacubitril. So this will inhibit AT1 receptors. These are the actions: vasodilatation, decreased sympathetic nervous system discharge, decreased sodium water retention because of decreased aldosterone, and decreased cardiac remodeling. And this atrial and brain peptide causes vasodilatation, natriuresis decreases remodeling and decreases renin and aldosterone, which is very, very good in case of resistant heart failure. Now, a word about phosphodiesterase enzymes and inhibitors. There are many phosphodiesterase inhibitors. In that, there are about 11 types which will inhibit cyclic AMP and but it has got more affinity for cyclic GMP. But some of them inhibit both of them and they enhance the level of cyclic AMP and GMP leading to therapeutically useful effects. Some of them are non-selective PD inhibitors: aminophylline, theophylline, pentoxifylline. Theophylline in case of bronchial asthma, pentoxifylline as a peripheral vasodilator in case of peripheral vascular diseases, or in Raynaud's phenomenon or thrombosis or all these cases. Selective PDE inhibitors, PDE3, dipyridamole, silastazole, vasodilatation and antipyretic aggregation, dipyridamole, coronary steal phenomenon, silastazole in case of peripheral vascular diseases, amrinone, milrinone are inotropes as well as levosimendan, which is used in acute heart failure. PDE4 inhibitors are roflumilast, which is anti-inflammatory and immunomodulatory. PDE5 inhibitors are sildenafil, vardenafil and tadalafil, which is used in erectile dysfunction and also in pulmonary hypertension, but never use sildenafil and nitrates together. Clinical pharmacology award, they are used to reduce spironolactone, epinephrine to reduce mortality. Beta blockers started only in compensated heart failure. Carvedilol is the drug of choice. AC inhibitors used everywhere unless contraindicated, like renal artery stenosis or angioedema. The ACE inhibitors in heart failure have got better efficacy due to raised bradykinin levels. ARBs are alternative. Salt, water, and physical activity restriction are important lifestyle modifications in CCF. This is again one more, this one where we have pharmacological actions in the treatment of heart failure. Same thing, which is again elaborately, which is done it. For example, AC inhibitors inhibits this angiotensin 2 generation, decrease AT1 activity, decrease afterload, preload, may cause hyperkalemia. So you have the whole range of this, so that you can use both in symptomatic heart failure as well as anti-mortality drugs, especially the spironolactone, which will mortality benefit may be independent of hemodynamic effect, may cause hyperkalemia. That's the only problem, which will decrease fibrosis, apoptosis, and also decreases the remodeling. So these are few of the things what you can note in these cases. So here the whole thing put in a nutshell, all the slides put together and put in a nutshell. First, we give symptomatic treatment, then preventive and reversing the disease progression and reducing the mortality by AC inhibitors, ARBs, beta blockers, MRA. Later on, adding ivabradine. Only if the heart rate is less than 100, even after adding metoprolol, add ivabradine. Otherwise, do not add. Sacubitril with valsartan only in resistant cases where there is still symptoms, but symptoms are there, but they are controlled with these drugs, but still symptoms are there. Then you add sacubitril with valsartan. The newer drugs are serelaxin and ularitide, which are still under trials. The general measures, as I told you, all these are the ones which you have to really take care of it. A review of positive inotropic actions, beta adrenergic agonists, dopamine, dopexamine, PD inhibitors, amrinone, milrinone, sildenafil, newer inotropes, levosimendan, calcium sensitizer, istraxamine. These I have put it because you might get it in exams, okay, or in your MRCP or USMLE or even in your NEET. That's the reason why I have put this. Levosimendan, istraxamine, neseritide, BRAF antagonist, tolvaptan and convaptan, cardiac glycosides, digoxin, which is only a inotropic agent, which has got diuretic effect, no action on heart rate, absolutely no action on heart rate. So lastly, clinical pearls. Okay, drug to initiate symptomatic. Oh God. Drugs to initiate. Little down, it will be nice. Drugs to initiate symptomatic heart failure and survival. The drug of choice is lisinopril, ramipril. AC inhibitors are better than ARBs. What is the action of AC inhibitors in the failing heart? They reduce preload. And after that, the whole lot of actions what I told you. After anti-mortality drugs, which are anti-mortality drugs? AC inhibitors, beta blockers, and mineralocorticoid receptor antagonists. The best drugs to improve heart failure symptoms and survival are venodilators. That is hydralazine, arterial vasodilator, but most often venodilator, that is isosorbate dinitrate, which is long-acting and no degradation in the liver. Beta blockers improve cardiac function in heart failure. How do they improve cardiac function? Not just by decreasing heart rate, it decreases remodeling. So you have to give it constantly at proper times so that long-term benefit is there. Metoprolol succinate should be used in place of metoprolol tartarate, because in all trials we have seen mortality with metoprolol tartarate than with succinate. That's the reason why we use metoprolol succinate, and that too extended release. Now, heart failure, it is not heart rate, it is heart failure with reduced ejection fraction, with stable heart failure symptoms, and with heart anti-mortality drugs, further improvement and survival. See, the patient is already on anti-mortality drugs, but still he has got symptoms, which has got, and also reduced ejection fraction like 35-40, heart failure, ejection fraction less than, say about 40 or 35. He has some of the symptoms, but he's already on all these drugs. Still, the patient has to have improvement and survival. Then use ARMI, sacubitril with valsartan, Why you are using valsartan? Because sacubitril will increase the concentration of angiotensin 2 and hence aldosterone, which will further deteriorate. For that reason, you block it by valsartan. What are the benefits of spironolactone? Mainly, it prevents cardiac hypertrophy and also fibrosis. It prevents electrolyte monitoring in dioxin, obviously potassium induced ventricular, digoxin induced ventricular arrhythmias, mainly by all these problems. Mechanism of milrinone increases contractility because it's a calcium. It increases calcium internally, intracellularly, and increases contractility. Which of the drugs has ADR of peripheral brightness or luminous phenomenon? It is evaporating. So when you continuously use evaporating, patient might have peripheral brightness in the what do you say the field of vision. In that area, there will be peripheral brightness. So in such cases, lower the dose of evaporating.